I have a question for all ultrasound neophytes out there, and the question is, can you tell a lake from a swamp? I'll try to convince you that, as strange as it may sound, this might be a relevant question to your practice. Since Almighty God, the Father of chest ultrasound, revealed us the ability of sonography in detecting the accumulation of free water into the lungs interstitial space, we have become familiar with B-lines and learned that we can easily detect pulmonary edema in the setting of acute decompensated heart failure. But what is a B-line? It's a laser-like artifact arising from the pleural line, moving synchronously with the pleural sliding. There is a direct relationship between the number of B-lines and lung fluid overload. So the more fluid accumulates, the more B-lines you get, and you might eventually end up with a sonographic white lung. The main features that we are used to associate with cardiogenic pulmonary edema are 1. The preservation of lung sliding, 2. Bilateral B-lines, and 3. The possible presence of pleural effusions. But there are at least 2 other things that should be present. First, homogeneity, meaning that equivalent regions on the 2 sides of the chest have to display a roughly similar amounts of B-lines, and second, what I call a gravitational gradient, which is to say the lung-dependent regions are more affected. It's easy to understand that whenever you find just one lung with a B profile and you believe in the Starling equation, you are most probably dealing with an inflammatory cause, as in the case of pneumonia. We Formites have already learned this notion from Peirce tweeted from the recent American Academy of Emergency Medicine Congress. But what if both lungs display B-lines? Is going to be just cardiogenic pulmonary edema? What if I told you you can differentiate the crystalline waters of a cardiogenic pulmonary edema from the insidious and muddy waters of non-cardiogenic wet lungs, as in the case of acute respiratory distress syndrome or bilateral pneumonia? There are 5 things you have to look for every time you perform a chest ultrasound, and be consistent in seeking whenever you get a patient that displays B-lines all over his chest. First, dishomogeneity. Anytime there is a gross difference in corresponding regions on the 2 sides of the chest, and anytime dependent regions appear not equally affected, this should raise your suspicion of a non-cardiogenic cause of dyspnea. Second, spared areas. Areas of normal lung interposed between areas of full-blown interstitial syndrome cannot be found in acute decompensated heart failure. These are very easy to detect since there is a clear borderline between spared areas and areas filled with B-lines. Here are some examples. Areas filled with B-lines are spaced out with areas of normal lung, displaying lung sliding and A-lines. Whenever you detect the presence of spared areas, there is no way you are facing an acute decompensated heart failure. Third, consolidation. Of course, it's pretty obvious that if you find a consolidation, there is something else going on. Mixed scenarios are frequent, but even if acute decompensated heart failure is present to some extent, whenever you find a consolidation, especially if bilateral, your treatment and workup is going to radically change. Consolidation might appear obvious, displaying a tissue liver-like pattern with well-depicted bronchograms, but may as well appear as subpleural echo poor regions enclosed between areas of interstitial syndrome. Fourth, pleural line abnormalities. The pleural line is what you should identify first when performing chest ultrasound. It should look like a thin, bright white line. In case it shows evident abnormalities, you know that peripheral lung parenchyma is affected from pathological disorders other than acute decompensated heart failure. Let's see some examples. it's easy to appreciate the difference between a normal pleural line and the abnormal appearance you get in most cases of non-cardiogenic dyspnea. In the latter case, the pleural line appears thickened and irregular. Fifth, lung sliding abatement. Lung sliding will appear reduced or, more notably, abolished, still in the presence of B lines. Frequently, the appearance of another distinctive sign called lung pulse will be noticed, that is, the subdural beating of the pleural line with cardiac oscillations. When performing chest ultrasound, you may divide the two sides of the chest into 4 regions according to the recent consensus guidelines published in 2012. But even if you don't, be systematic and always count the two sides of the chest, comparing superior from inferior and anterior from lateral regions. Pulmonary fibrosis may cause pleural line abnormalities and be associated with a dishomogeneous B lines distribution. Substantial sonographic changes will be present, though, only in case of severe disease. The evidence behind this is not earth-shaking, but convincing. Despite the fact this might be viewed as an expert approach to chest ultrasound, recognizing even some of the features associated with non-cardiogenic pulmonary edema will anyway help you in optimizing the treatment and workup of your dyspnoic patients right at the bedside. Thanks for your attention.